Three, two, one. Over to you, sir.
Good evening, everyone. At the outset, I would like to thank Dr. M.B. Agrawal, sir, for giving us an opportunity to participate in today's webinar, which is on T-cell lymphoma, an update from ASH 2021. On behalf of Adelaide Oncology, it's indeed a great pleasure to welcome guest speaker of today's webinar, Dr. Alison Moskowitz, who is from very reputed Memorial Sloan Kettering Cancer Center, New York, USA. A very warm welcome to our discussants, Dr. Bhavin Shah, Dr. Abhishek Kakru, Dr. Prantar Chakrabarti, Dr. Rajkumar Ramaswamy, Dr. Narendra Kumar Thota, Dr. Saurabh Bhave, Dr. P.P. Abdul Shahid, Dr. Shilpa Gupta, Dr. Dipankar Bhattacharya, Dr. Akhil Kapoor, and Dr. Aryan Jain. I am sure all the discussions will make today's webinar a very, very interesting one. A very warm welcome to all the participants for sparing your valuable time this Saturday evening. I have just a couple of slides to present you to brief you about Adelaide Oncology. You build hope, we accelerate it. Every moment of life is precious for cancer patients. Adelaide has been acknowledged as the fastest growing oncology company in India because of the following reasons. We do have our own state-of-art manufacturing facilities in India and Uzbekistan. In all, we do have 4 cytotoxic facilities, out of which one is of API. So we are truly a backward integrated oncology company. We have presence in majority of the corporate as well as the government hospitals of the country. Our major thrust lies in new product development. In this financial year, we have already introduced 6 novel molecules and expected to launch 4 new novel molecules again in next couple of months' time. We bring cost-effective medicines, and our major emphasis is on patients' first approach. We are not only growing in India, but expanding our wings globally as well. So far, we have triggered audit for PICS, INVIMA, UGMP, COFEPRIS, ANVISA. So once that is done in next financial year, we believe that will be available in many more countries in coming time. Patient first is our guiding principle. Adelaide is among very few companies who is working on NDDS formulation. So we have NDDS formulation for docetaxel, gemcitabine, paclitaxel, elaspergines, and very soon we'll be launching azacitidine oral. Our patient support program is very, very unique. So the drug reaches to the patient within 24 hours time once we receive a request from the respective consultant. We are continuously working to disseminate knowledge through awareness campaigns like Champions of Hope and Buzz the Myth campaign. As I said that the API as well as the formulation both are in-house, we are providing the highest quality medicine at very affordable cost. Your wish can be a reality very soon with launch of MDSO, that is azacitidine tablet. Azacitidine tablet will be available in 2 different strengths, that is 200 mg as well as 300 mg. And hopefully the drug will be available in the market in the first week of January itself. So it's within the next 2 weeks time, the drug will be available for your patients. Now to commence the event, I would like to hand over the stage to our very own, very respected Dr. M.B. Agrawal, sir, please. Thank you so very much.
Thank you, Mr. Ashutosh. Good evening to one and all. Today, our guest speaker is Dr. Alison Moskowitz from Sloan, New York, US. And she's going to lecture on how do I manage T-cell lymphomas, including an update from ASH 2021 which was concluded just a few days ago. This webinar is brought to you by Mumbai Hematology Group, supported by ADLI and managed by Mice Ideas. I thank Mr. Ashutosh Shukla and his team from ADLI Oncology, Rajesh Kalpesh and team from Mice Ideas, Executive Committee of Mumbai Hematology Group, our guest speaker, Dr. Alison Moskowitz from Sloan. All our discussants were themselves eminent hematologists, medical oncologists. You participants for sparing your Saturday evening for the academics. Tomorrow morning at 11:30 a.m., we have guest speaker from Iceland, Professor Paul Onandarsson, who is going to speak to us on monitoring of warfarin therapy, a very innovative approach where PT-INR is replaced by fixed PT, fixed NR. Discussants today include faculty from Ahmedabad, Kolkata, Madurai, Sikandarabad, Trivandrum, Mumbai, Lucknow, Varanasi, and Chandigarh. We have Dr. Abhishek Kakru from Vedanta Institute of Medical Science, Ahmedabad. Dr. Pranta Chakrabarti from Apex Institute of Medical Sciences, Kolkata. Dr. Saurabh Bhave from Tata Medical Center, Kolkata. Dr. Rajakumar Ramaswamy from Velamal Specialty Hospital, Madurai. Dr. Narendra Kumar Thota from Krishna Institute Medical Sciences, Sikandarabad. Dr. Abdul Shahid from KIMS Cancer Center, Trivandrum. Dr. Shilpa Gupta from Holy Spirit Hospital, Mumbai. Dr. Dipankar Bhattacharya from Medanta Hospital, Lucknow. Dr. Akhil Kapoor from Tata Memorial Hospital, Varanasi. And Dr. Arihant Jain from Postgraduate Institute, Chandigarh. My pleasure to introduce Dr. Alison Moskowitz again. She has been our regular speaker. She was in Mumbai a couple of years ago, and many of you witnessed her lectures, met her in person, and what a lovely personality she is. She has also been lecturing us during this pandemic, during last 2 years, and I think this is third or fourth time she is with us. Her formal introduction includes that she is Associate Attending Clinical Director, Lymphoma Services at Sloan, New York. She received her medical degree from Albert Einstein, Bronx. She completed her internal medicine residency and internship at Columbia University Medical Center, followed by hematology, medical oncology fellowships at Sloan and Cornell. She's board certified in internal medicine, in medical oncology, and in hematology. She holds professional membership of AMA, ASCO, ASH. She's lectured and authored and co-authored peer-reviewed articles on two very important subjects which she loves, the Hodgkin lymphoma and the T-cell lymphoma, and also stem cell transplantation. Her primary area of research are developing novel treatments for Hodgkin lymphoma and T-cell lymphomas. Today, she is going to tell us about how you manage T-cell lymphomas with an update from ASH 2021. I invite her to give this talk. Thank you. And over to Dr. Moskowitz.
Thank you so much for that really kind introduction. It's always fun to join you. So I'm just going to share my slides. Just put this on. Okay. Is that showing the right slide?
Yes.
In the right form? Okay. Well, thank you so much. It's really great for me, helpful for me to actually put together a talk right after ASH, with an integrating how some of the new data integrates into how we manage T-cell lymphoma. So thank you for this introduction. So just as far as an overview about what I plan to cover, I'm going to touch upon improved classification in T-cell lymphoma, which I hope and believe will help inform our treatments and improve outcomes for patients with T-cell lymphoma in the future. I'll talk about updates in frontline management of relapse and refractory disease, as well as emerging therapies. So just as far as a background, when we're talking about T-cell lymphoma, in general, for the purpose of this talk, I'll be talking about the most common T-cell lymphomas, which in the International T-cell Project is peripheral T-cell lymphoma not otherwise specified, angioimmunoblastic T-cell lymphoma, as well as anaplastic large cell lymphoma. And in general, we've thought these most common nodal T-cell lymphomas are just, basically 3 or 4 diseases. There's anaplastic large cell lymphoma, which is broken down into ALK positive or ALK negative, peripheral T-cell lymphoma not otherwise specified, and angioimmunoblastic T-cell lymphoma. But now with improved classification, we actually have more diseases than this. But this is where we're coming from. And when we think about peripheral T-cell lymphoma, this is really the diagnosis which we think of as the wastebasket diagnosis. It's the one that doesn't fit into, patients, their pathology doesn't fit into the other diseases, and therefore we call it peripheral T-cell lymphoma, not otherwise specified. And as a result, it's very heterogeneous. Generally, we think of this as a nodal disease, but there's a high prevalence of extranodal involvement. Typically presents as advanced stage disease and aggressive. And now we're starting to learn that this does represent some specific entities, and this has come across with gene expression profiling, which has been able to identify subgroups within PTCL-NOS, and in particular, a subgroup that is associated with overexpression of TBET21, as well as overexpression of GATA3. And these subgroups do predict prognosis, and so they are helpful in this way. And we also know now that with immunohistochemical staining, we can potentially identify whether a patient with PTCL-NOS has GATA3 type or TBET21 type, and in particular, staining for TBET21 or CXCR3 would identify a patient with PTCL TBET21. And in contrast, staining for GATA3 or CCR4 would identify a patient with GATA3. And this is about 85% accurate when you compare it to the gene expression profiling. And we expect about 2/3 of cases will have the TBET21, whereas 1/3 would have the GATA3. And even with this immunohistochemical staining, this was found to be prognostic, with the GATA3 patients having a less favorable outcome, whether you look at immunohistochemical staining or gene expression profiling. And where this actually is potentially helpful in managing our patients is that these particular subtypes are associated with upregulation of certain pathways that we can target. So, for example, the GATA3 subtype is associated with upregulation of PI3 kinase, and TBET21 is associated with upregulation of JAK-STAT, NF-kappa B, and also associated with immune modulation. And so we're not yet at the point where we're able to say for sure whether these predict responses to these targeted agents, but it certainly raises some hypotheses as far as how we might treat these patients in the future. With angioimmunoblastic T-cell lymphoma, this is a disease that is characterized by a polymorphous infiltrate, mixture of small and large lymphocytes, and the tumor cells, the neoplastic cells, originate from a T follicular helper T cell, and the T follicular helper T cells are characterized by expression of certain markers that are characteristic of T follicular helper phenotypes, such as CXCL13, CD10, BCL6, PD1, and ICOS. About 1/3 of these patients also have positivity for CD30. The pathology or the histology is characterized by containing prominent high endothelial venules, and we also often see EBV positive, CD20 positive cells in the microenvironment. And that reflects the fact that these patients sometimes can relapse with a diffuse large B-cell lymphoma, which is basically a transformation of those EBV positive cells. And so even with angioimmunoblastic T-cell lymphoma, we now have some improvement in these basically group of entities, in particular amongst the patients with peripheral T-cell lymphoma not otherwise specified. It's now recognized that a subset of these patients have some of the mutations that are classically seen with angioimmunoblastic T-cell lymphoma. So these include mutations involving epigenetic modifying genes such as TET2, IDH2, and DMT3A. And the patients with PTCL-NOS that contain these mutations, they also typically have histology that looks like that look similar to angioimmunoblastic T-cell lymphoma, but just may not meet all of the criteria. And for example, they would have tumor cells that have at least 2 of the markers for a T follicular helper phenotype. And this group, the subgroup of PTCL NOS, has kind of been now named nodal T-cell lymphoma with T follicular helper phenotype to indicate that this is a subgroup within PTCL that PTCL NOS that we expect to behave similar to angioimmunoblastic T-cell lymphoma and may respond similarly to the type of agents that we use with this disease, such as epigenetic modifying agents such as HDAC inhibitors or hypomethylating agents. And then finally, with anaplastic large cell lymphoma, this is also a disease that we're now subgrouping more. This is a disease characterized by effacement of the lymph node with CD30 positive T cells. These T cells tend to have these characteristic appearance under the microscope that are called hallmark cells or wreath cells. And just showing you here how we typically would expect to see sheets of CD30 positivity. These can be the ALK positive is characterized by overexpression of ALK, and as you can see here. But the ALK negative patients are now subdivided based upon whether or not they have rearrangements of DUS22 or TP63, and if they have none of these, then we would consider those to be the triple negative anaplastic large cell lymphoma. And the TP63 is the least common of these, which is a thankful thing, because this is the rearrangement that is associated with the least favorable outcome. There is a suggestion that patients with the DUS22 rearrangement may have a more favorable outcome, and those patients are shown here on the blue curves, where you can see that their outcome is actually very similar to the ALK positive anaplastic large cell lymphoma, suggesting that maybe these patients may be managed similarly to ALK positive anaplastic large cell lymphoma, although there's some conflicting data. Sorry about my dog. There's some conflicting data with that. And so we're not yet really using this data to impact our management, and we really need larger studies to help confirm this. So now bringing it all together, even amongst these 3 entities, we have many more entities below them, and hopefully with time, this will help guide our therapy, and particularly with the angioimmunoblastic T-cell lymphomas of T follicular helper phenotype. Now we have these 3 entities that kind of fall under this group that likely should be treated similarly. And amongst the PTCL NOS, we have the GATA3 and the TBAT21, which potentially should be treated differently, in the future once we, have a better sense of which agents are better in these diseases. So starting with the frontline treatment, there's not really much of a change from last year, and I'm going to show you some updates from the Echelon-2 study from ASH. But generally, for these more common nodal type T-cell lymphomas, our general approach is to start off either with a CHOP plus etoposide induction followed by an autologous stem cell transplant, and then for the CD30 positive entities, using brentuximab plus CHP followed by an autologous stem cell transplant. And just going back to what we expect as the typical outcome for patients with T-cell lymphoma who get CHOP-based therapy alone. And this is from the International T-cell Project, which was a large retrospective analysis of patients with T-cell lymphoma. And primarily the most common regimen administered in this series was CHOP, and virtually no patients received consolidation with autologous stem cell transplant. So this is basically what we use as our benchmark of what we expect with just CHOP-based therapy. And so as you can see, the ALK positive patients tend to do more favorably and tend to do quite well with just CHOP-based therapy alone, with a 5-year overall survival of 70%. Of course, we expect that to be better now that we're using brentuximab in the setting. ALK positive, the ALK negative anaplastic large cell lymphoma patients do a little, not as well, but still better than the other T-cell entities. And then the angioimmunoblastic T-cell lymphoma and peripheral T-cell lymphoma not otherwise specified are, tend to be grouped down here lower on the curves with a 5-year overall survival of about 30%. So the basis for using upfront CHOP plus etoposide and autologous stem cell transplant primarily comes from this fairly large phase 2 study that included 166 patients with T-cell lymphoma, and patients received 4 to 6 cycles of induction chemotherapy with CHOP or CHOP plus etoposide. The etoposide was only used for patients who are less than 60 due to higher toxicity with patients over 60. And then for patients who responded, they went on to consolidation with autologous stem cell transplant. And by intent to treat analysis, you see the progression-free survival curves here. And as you can see from these overall survival, 5-year overall survival, in general, the 5-year overall survival is about 20% better than what you saw with the peripheral, with the International T-cell Project. Of course, there's so many caveats with comparing a prospective phase 2 study with a retrospective analysis, and there's certainly a lot of bias, and better patients or more fit patients would likely go on a clinical trial like this. But there's certainly a suggestion that this approach looks better than CHOP-based therapy alone, and this has been the basis of this treatment approach. And so even for peripheral T-cell lymphoma, not otherwise specified in angioimmunoblastic T-cell lymphoma, we expect about a 5-year overall survival of about 50% with this approach. But now we have brentuximab that we're using in the frontline setting for patients who have CD30 positive disease. And the basis for brentuximab comes from its high activity in anaplastic large cell lymphoma, as well as the other CD30, fairly good activity in the other CD30 positive T-cell lymphomas. So I'm showing you here the data from the study with brentuximab in relapse and refractory anaplastic large cell lymphoma, which showed the overall response rate of 86%, with 57% of the patients having complete response. And even in the patients with non-anaplastic large cell lymphoma, this is a small study that included patients with angioimmunoblastic T-cell lymphoma as well as PTCL NOS. And the requirement to get on the study was to have at least 1% CD30 positivity or more. So really, they could have fairly low CD30 positivity. But we saw here with angioimmunoblastic T-cell lymphoma that the response rate was 54% with brentuximab. And so that looks quite promising with this drug as a single agent, not quite as good with PTCL NOS, with only about 1/3 of the patients responding. But this is the basis for evaluating brentuximab earlier in the treatment for T-cell lymphoma, and has been the design for the Echelon-2 study, which was a phase 3 study. It was placebo-controlled study, which I think was really a very important strength of the study, where patients with T-cell lymphoma were randomized between brentuximab, CHP versus 6 cycles of CHOP. And then patients could go, and then after the 6 cycles of treatment, it was really up to the treating physician whether the patients would then just be monitored or go on to consolidation with an autologous stem cell transplant. This study was designed to enrich for patients with anaplastic large cell lymphoma, so that it was really designed to statistically see if there was a difference in outcome for that group. And so as a result, about 70% of the patients enrolled on the study had anaplastic large cell lymphoma. Patients who have ALK-positive anaplastic large cell lymphoma had to have at least 2 risk factors based upon IPI. So they were aiming not to include the most favorable patients. And then, of course, it included the other T-cell entities as well, but they represented a small subgroup. So just to highlight who was on the study, as I mentioned, about 70% of the patients had anaplastic large cell lymphoma, and then much smaller numbers amongst the other entities. What's nice about brentuximab plus CHP is that the side effect profile is similar to what we see with CHOP. So it makes it much easier to use this regimen or consider using this regimen. Even in older patients, I've been able to get through the treatment and with fairly good tolerability. As expected, the main side effect that we really have to watch out for is peripheral neuropathy, but we see that with CHOP also. I feel like we're fairly comfortable with managing that, and with brentuximab, the main thing is just being on top of the neuropathy and considering dose reduction or potentially holding the drug, depending upon the severity of neuropathy. But as you're likely aware, the ECHELON-2 study showed a significant improvement in progression-free survival for the patients who received brentuximab plus CHP compared to CHOP. Even at 3-year, the 3-year progression-free survival continued to show a benefit. And really quite impressive was the fact that it also showed an overall survival benefit as well. And so this is really has changed our management, and this is what we're using routinely. Now, an update from ASH, Steve Horowitz presented the subgroup analysis from this study, and just kind of showing you this as the highlight of the subgroup analysis. Of course, there's been all this interest in, okay, well, what happens to the other entities? We know that this is better for anaplastic large cell lymphoma, but does it make a difference for peripheral T-cell lymphoma not otherwise specified and angioimmunoblastic T-cell lymphoma? And the bottom line is that the curves are shown here, and you can see that they're basically interacting and or overlapping, and so there wasn't a clear significant benefit of using brentuximab for these patients. That being said, though, the study was not designed to look at these subgroups in this way. These really represent a very small group amongst the entire study, and this really has not impacted my practice as for a patient with CD30 positive peripheral T-cell lymphoma not otherwise specified, given that I know that brentuximab has single agent activity in the relapse and refractory setting. Outside of a clinical trial, I would still use the BV-CHP regimen. And likewise for angioimmunoblastic T-cell lymphoma, quite surprisingly, actually, the patients on the CHOP arm numerically look a little better than the patients on the BV-CHP arm. But again, there's no statistical significance, and this is represents a very small group amongst the study. And so overall, based upon the improvement in both progression-free survival and overall survival for the group as a whole, this is still my treatment of choice. So just to touch upon some new regimens that were evaluated or presented at ASH, I do want to mention this regimen that was presented by Alex Herrera, which is combining brentuximab plus CHP, and then as well as etoposide. And this is, of course, this is a regimen that a lot of people have been interested in because there's concern about using BV-CHP and not including the etoposide, which we think of as an important drug for T-cell lymphoma, particularly for patients with T-cell lymphoma who are presenting with evidence of HLH. So this is the schema for his study. Patients received 6 cycles of brentuximab plus CHEP, so CHEP, and then they could get consolidation with an autologous stem cell transplant. And whether or not they got consolidation, they then could go on to get maintenance therapy with brentuximab for up to 10 additional doses. Overall, there were 48 patients included on this study. And as we would expect, the breakdown amongst the types of diseases that were enrolled on the study included about a third of patients with angioimmunoblastic T-cell lymphoma, about a third with anaplastic large cell lymphoma, a little less with PTCL NOS at 23%. What was quite impressive, it's a small study, but the complete response rate at the end of brentuximab plus CHEP was 80%, which is quite high. We expect when you think about CHOP plus etoposide alone, typically we see a complete response rate of about 60%. And so it appears that potentially the brentuximab is adding a benefit here. But of course, again, it's comparing different studies and hard to know for sure. But this is certainly impressive. And importantly, the regimen is associated with increased toxicity because of the etoposide, particularly hematologic toxicity. But I think that, this indicates that, for bringing in etoposide, is feasible and certainly associated with fairly good activity. And, I think it's something that we strongly would consider for someone who is young and fit with no other, no significant comorbidities. And particularly for somebody who is presenting with evidence of HLH as well. And so far, with limited follow-up, it looks like this regimen is fairly, looks pretty durable with an 18-month progression-free survival of 61%. So another regimen that was presented that I think is really interesting and exciting, particularly for the entities of the T follicular helper phenotype, was presented by Jia Ruwan from Cornell, and that's using oral azacitidine plus CHOP for peripheral T-cell lymphoma. So on this study, patients start off with single agent azacitidine alone for about a week before beginning CHOP. And the idea for this is to potentially sensitize the patients to chemotherapy, also to get a sense of the single agent activity, and this allowed them to do some correlative studies as well. But also, single agent azacitidine has activity in relapse and refractory angioimmunoblastic T-cell lymphoma and the other T follicular helper entities. We know this based upon a very small study, but it certainly is a reasonable agent for this for that entity. And so basically this regimen included the azacitidine given for 7 days before the first cycle of CHOP, and then basically for 14 days with every cycle, for a total of 6 cycles. This was a small study. It included only 21 patients. The aim was to enrich for patients with T follicular helper phenotype. So they did represent the majority of the patients. It was 17 out of the 20 evaluable patients had T follicular helper phenotype. But you can see once again, the complete response rate, particularly amongst the T follicular helper phenotype patients, was 88%. So certainly looks quite promising. And now with some follow-up, we see that about 2/3 of patients remain in remission, and even looking a little better for the patients with the T follicular helper phenotype. So what I think is really exciting is that there is an ongoing phase 3 study that is led by a collaboration of many of the intergroup of the cooperative groups in the US, and this is led by the Alliance Group. And this is for patients with T-cell lymphoma, and patients will be randomized to potentially three different regimens. One of the regimens is duvelisib plus CHOP or CHOP. And I'm going to talk to you a little bit more about duvelisib as well as far as the single agent activity in the relapse and refractory setting. The second regimen is CC486, which is oral azacitidine. And so that will be combined with CHOP plus etoposide. And then the third arm will be the control arm, with patients receiving CHOP or CHOP plus etoposide. The patients are receiving CHOP if they're over 60. CHOP is given for patients who are less than 60. This is particularly for patients who lack CD30 expression. They have to have less than 10% CD30 expression by immunohistochemical staining, which was the cutoff that was used for the Echelon-2 study, where all patients had over 10% expression. Right now, the study just started, and so there's currently a safety run-in of the study where just the duvelisib plus CHOP and CHOP regimen is being evaluated to evaluate for toxicity, since this is the first time that those drugs are being combined. And once we're done with that safety run-in, assuming we see safety, the phase 3 randomized study will begin. So I feel like this is really exciting. The study is aimed to stratify for patients with T follicular helper phenotype. And I'm hoping that we'll learn about how we use these novel agents in the frontline setting, certainly through all the planned correlatives for the study as well. So in the relapse and refractory setting, the general approach that we use is to aim for an allogeneic stem cell transplant, and also to bring in novel agents early, particularly through clinical trials. And I feel really lucky, even through the pandemic, as you know, at Memorial, we've been able to keep many of our studies open, and we often have a number of options for patients with T-cell lymphoma, which makes us really lucky, really, in a way. So as far as the reason why we're really aiming for an allogeneic stem cell transplant, you know, that comes from both retrospective data. Now, first I'm showing this registry data where it actually shows that for patients with relapse or refractory T-cell lymphoma, the outcomes actually look a little better for patients who are consolidated with auto transplant compared to allo transplant. The problem with this registry data is that this really was enriched for patients with anaplastic large cell lymphoma. And so I think this data is helpful in thinking about a patient with anaplastic large cell lymphoma who develops relapse and refractory disease, because for that one entity, I would consider potentially using an auto transplant in the relapse and refractory setting, provided an auto transplant wasn't used in their frontline setting. But for all the other entities, really using an allo transplant is appropriate, and that's based upon some data from our institution where we used to use the standard ICE followed by auto transplant for patients with relapse and refractory disease. And certainly we saw that the response rate to ICE is high, about 70%. But for patients who then went on to an auto transplant, virtually every patient relapsed within 6 months of treatment, or at least half of the patients relapsed within 6 months of treatment. You can see that the curve looks quite disappointing. And so we really don't think of this as a curative option for patients with all of the other T-cell entities. And in contrast, when we look at a large retrospective analysis of patients who receive allo transplant at various different centers, this was an analysis led by Dr. Neha Mehta Shah, who's now at Washington University. As she showed here, that we see the 5-year progression-free survival, it ranges about 40 to 50% for patients who are able to go on to an allogeneic stem cell transplant. So this tends to be our goal for patients. And in particular, we also learned from her analysis that the depth of the patient's response prior to transplant is really what's important. So patients having a complete response before transplant are the ones who did the best. So based upon this data, this is the algorithm that we follow for patients with relapse and refractory disease. For a patient, overall, if the patient is fit and appropriate for an allogeneic stem cell transplant, we're already thinking about it from the moment they have relapse and refractory disease. And for these patients, if we already know who their donor is, let's say they have a sibling donor and they're eligible, then for that patient, I actually might consider the combination chemotherapy such as ICE, given that we do expect a fairly high response rate. The problem with these regimens is that we know that we can't continue them on a long-term basis. But for patients where we just need a quick response to get them to transplant, I think that that's a reasonable way to go. Many patients, we really don't know whether or not we're going to be able to bring them to transplant. Maybe we don't know if there's a donor, or we don't know if the patient may or may not be eligible due to their age or comorbidities. And so for those patients, often we're opting for single or doublet treatment or enrollment on a clinical trial, because many of these treatments that we're using can be, as long as the patient's responding to the treatment, they can be continued on an ongoing basis. And that's helpful for patients for whom we don't know the timing of their transplant. Certainly, if they have a very good response and we're ready for transplant, we can take them to allo transplant, or if we determine that they are not going to go on to transplant, we can just keep them on this treatment or continue with sequential treatment going forward. And then finally, we have patients who we know will never take them to transplant due to their comorbidities. And so again, I think for these patients, single or doublet treatment, more milder treatment that hopefully can provide some more durable disease control on an ongoing basis is appropriate for these patients. So unfortunately, the drugs that are approved for T-cell lymphoma do not have very good activity. They're certainly beneficial for some patients, but when we look at romidepsin, belinostat, and pralatrexate, the response rates are 25 to 30% in unselected T-cell lymphoma patients. Now, for the patients with the T follicular helper type lymphomas, the HDAC inhibitors such as romidepsin and belinostat tend to have better results, and so I do tend to use those for those patients. In contrast, brentuximab, as I already showed you, has high activity in anaplastic large cell lymphoma, so it's certainly efficacious in a select patient population. As far as the emerging therapies, I kind of already touched upon the fact, that I'll talk about duvelisib, which I think is really a very exciting drug for T-cell lymphoma that, I think we're going to see a lot of. And as you can see, we're now are looking at it in the frontline setting, but I'll tell you about the data in the relapse and refractory setting. And Dr. Horowitz has run a phase 1 study with romidepsin plus duvelisib, and I'll show you the data with that combination. JAK inhibition has been an area that we've been interested in, and I'll show you our data with the phase 2 study with ruxolitinib, which is just recently was published in Blood. And then also JAK1 inhibition has been looked at as well. And I'll show you data, not from this ASH, but actually from last Lugano. And then finally, a new area that is really looking very promising is inhibition of EZH1 and 2, and particularly in some diseases that are very difficult to treat. So duvelisib initially looked very active in a phase 1 study that included all different types of lymphomas, but there was a signal that it looked quite active in both PTCL as well as CTCL, with a response rate of 50% in PTCL, which, as you can see, already looked better than the drugs that are currently approved. And so this has led to the PRIMO study, in which patients with T-cell lymphoma are starting off. Actually, originally in the study, they looked to determine the optimal dose of 25 BID versus 75 BID, but ultimately it was found that the optimal dose was starting with 2 cycles of 75 BID followed by 25 BID going forward. So this study is currently accruing, and an update was presented at ASH by Dr. Brammer, and this includes 78 patients on the study. And I'm just showing you just a kind of a breakdown so you can see that, as expected, the majority of the patients had PTCL NOS, and fewer patients with angioimmunoblastic T-cell lymphoma. And just like what we saw in the phase 1 study, the overall response rate is looking fairly similar, with 50% of the patients having a response and about a third of the patients having a complete response. So this drug is looking fairly reliable as an option for relapse and refractory disease in T-cell lymphoma, and certainly a drug that many of us are interested in building upon for combinations. And so I've presented this data before, but just to show you where this study is. And this was a phase 1 study that Dr. Steve Horowitz led, building upon duvelisib. He looked at both the combination of duvelisib plus romidepsin, as well as with bortezomib. And it was really the combination with duvelisib plus romidepsin that looked the more promising and the safest. And so just showing you the overall results that he had presented at Lugano. And he also presented the data at this past ASH, where this combination looks a little better than what we see with either one of the drugs alone, with overall peripheral T-cell lymphoma patients having an overall response rate of about 58%. And then with the most common entities, we see good activity amongst all of these diseases. Something that was very interesting that was observed on the study was that the typical side effects that we see with PI3 kinase inhibitors, such as hepatitis or colitis, seem to be less common when you combine the duvelisib with romidepsin. So it seemed that potentially romidepsin is blunting some of the toxicity associated with the drug, but also helping to potentially enhance the activity. So as I mentioned, we're also interested in looking at targeting the JAK-STAT pathway. And this is based upon the fact that many different T-cell lymphomas have mutations amongst genes in the JAK-STAT pathway, leading to activation of this pathway. Some of the diseases are just almost, very commonly associated with JAK-STAT activation, such as TPLL, as well as LGL. And in addition, many of these entities also have evidence of expression, upregulation of the JAK-STAT pathway that we can measure by immunohistochemical staining, by staining for phospho-STAT3. And so this is also evidence that, potentially this is a target that we should be focusing on. And we have led a study that was open at both Memorial as well as Dana-Farber, Cornell, and University of Miami, in which we aimed to evaluate all comers with T-cell lymphoma, but we really aimed to enrich for patients who have diseases associated with activating mutations in JAK-STAT, as well as overexpression of phospho-STAT3. And then also, because we didn't necessarily know if that was important, we also included patients who had neither. And so there were 3 different cohorts in the study based upon whether or not the patients had activating mutations or functional evidence of JAK-STAT activation or neither. Patients received ruxolitinib 20 milligrams BID. And this is just a summary of the results from the study. This is the visual abstract that is will be in Blood. And basically what we saw when you look at the clinical benefit rate, which includes response rate as well as durable, stable disease for at least 6 months, we certainly saw a enhancement or more activity in the patients who have evidence of JAK-STAT activation compared to patients who do not. And I'm showing you here just an example of a patient with their lymph nodes showing very extensive staining for phospho-STAT3. And you can see this is one of our, an excellent responder, who ended up achieving a complete response. He's actually remained on treatment. This is a patient who was heavily treated with angioimmunoblastic T-cell lymphoma, and he's remained in complete response for actually a couple of years and continues on therapy. And one thing that we learned through multiplex immunofluorescence was that we looked at various different markers, of course, including phospho-STAT3 and phospho-STAT5, but also we looked at evidence of upregulation of PI3 kinase pathway, such as phospho-S6. And what we found was that patients who had high phospho-S6 were less likely to respond to ruxolitinib. So suggesting that potentially targeting the PI3 kinase pathway may help us overcome resistance to this agent. And so that's the basis for a phase 1 study that we currently have ongoing. It's just recently opened, so we just have a few patients who have started so far, but we're looking at the combination of targeting both of these pathways with ruxolitinib and duvelisib. So another approach to targeting the JAK-STAT pathway is with this more specific JAK inhibitor, JAK1 inhibitor. So this was a study that included 47 patients with T-cell lymphoma that was updated at this past Lugano meeting. And the activity looks, once again, mostly patients with PTCL or angioimmunoblastic T-cell lymphoma. And the overall response rate looks fairly high, with 47.6% of the patients responding to treatment. This is a bit higher than what we saw with ruxolitinib. And one of our worries about ruxolitinib is that our dosing might be limited by the side effects, potentially be due to targeting JAK2 in addition to JAK1. And so it's possible that a JAK1 inhibitor may be a better approach for these diseases, although we don't have yet, further information about these patients, about their JAK-STAT status as far as mutation status or evidence of upregulation of phospho-STAT3, but this is certainly something that looks very interesting. And then finally, the last target that I think is particularly important to be thinking about is valemetostat, as this drug is really moving along in clinical trials. So this is a drug that targets both EZH1 and EZH2. So it's an epigenetic modifying agent. So, another agent that we would think may be important for the T follicular helper entities. But it also turns out that EZH1 overexpression is important in the development and progression of HTLV1 associated lymphoma. And so there was already, hypotheses that this might be important for that disease. So far, I'm just showing a summary of the data with this drug so far in the phase 1 study. Again, seeing nice activity for the patients with PTCL, similar to what we saw with duvelisib, with about 50% of the patients responding. But importantly, even patients with HTLV1 associated lymphoma, we're seeing about 50% of the patients responding. And results from a pivotal phase 2 study in HTLV1 associated lymphoma that included 25 patients confirm this activity. And there's currently an ongoing global phase 2 study in T-cell lymphomas that also is including HTLV1 associated lymphoma as well. And we're currently enrolling onto that study. So overall, I believe that the future is bright for T-cell lymphoma. I think that the improvement in precision and classification will be very helpful in the future in more personalized therapy for T-cell lymphoma, which I hope will end up improving overall outcomes. And I think that these new targets that we're evaluating in T-cell lymphoma, we're going to see them more and more moving up into the earlier treatment for these diseases. And I think that we'll hopefully learn through these relapse refractory studies, through correlative studies, who are the best patients for these agents, and how do we predict resistance? And so how do we best combine these drugs? And so we are learning quite a bit. And I think that overall, we're making some progress, and I'm excited, as we see the outcomes of these ongoing studies, and as we have more drugs available for these patients. So anyway, thank you so much for listening, and I'm just happy to take questions, happy to discuss this further.
Thank you so much, Dr. Allison, for putting all this together and updating us from the ASH as well. It was wonderful, very, very lucid lecture. Enjoyed listening to you. Before I ask my faculty to ask questions to you, I have one question. So CD30 positivity, your cutoff is 10% to include brentuximab in the upfront treatment?
Great question. So that was the cutoff for Echelon 2. It's FDA approved for any CD30 positivity, so we can use it for any CD30 positivity. And outside of a clinical trial, I actually do tend to use it for any CD30 positivity. There is actually a clinical trial ongoing for the patients who have less than 10% CD30 positivity, with just looking at BV-CHP in that setting, just to confirm the activity. So we will get more information about the patients with the lower expression. But my practice is to still use brentuximab, even if it's less than 10%.
Right. The second question I have, so that is your preferred regimen with compared to CHOEP?
It is. The data for including etoposide in the frontline treatment really comes from, kind of shaky data. It's not really strong data to include etoposide. It's, based upon retrospective looks at older prospective studies. There's just a suggestion that etoposide should help the, I think it's more of a suggestion that etoposide helps as opposed to any clear proof. So in general, I will use the BV-CHP regimen rather than the CHOEP regimen for patients who have the CD30 positivity. I do like the fact that we now have some safety data with including etoposide in that regimen. So for a patient who's, I might now consider it for a patient who's presenting with a little bit more aggressive course, particularly someone, as I mentioned, who has evidence of HLH. But in general, no, I would still favor the BV-CHP.
Okay, one question from the audience. which is related to your selection of patients for upfront autologous transplant. Is it blanket for all the patients or you're selective?
So for at least for the diseases that I mentioned in this talk, most patients we will strongly consider it. The patients who, for patients who have ALK positive anaplastic large cell lymphoma, since they tend to do better with, CHOP-based therapy alone, or now we would use BV chip. Those patients will generally not necessarily consider an auto transplant, although when you look at the outcomes for those patients based upon IPI, patients with 3 or more risk factors on IPI, who even if they have ALK positive anaplastic large cell lymphoma, those patients don't have a good outcome. Their progression-free survival really falls below 50%, and so even for the higher risk ALK positive patients, and then for all of the other nodal-based T-cell lymphoma patients, I will strongly consider upfront upfront transplant. But the patients have to have a complete response. So if they're not achieving a complete response, then we're going to be going on to second-line therapy or beyond.
Thank you, Dr. Deepankar.
Thank you, ma'am, for the excellent talk. My question is, is there any role of brentuximab maintenance in transplant ineligible patient and even post-transplant CD30 positive T-cell lymphomas?
So great question. So this comes up a lot, in my patients, because I certainly have a lot of patients who are not eligible for transplant. And actually the original phase 1 study that evaluated BV-CHP for patients with T-cell lymphoma included maintenance brentuximab. So those patients did not go to transplant on that original phase 1 study. And then they received 10 doses of brentuximab maintenance after the first 6 cycles of BV-CHP. It was a small phase 1 study, but the outcomes were excellent. And so I often will go back to that, for the patients who are not going to transplant. That's the approach I use. I continue them on with maintenance brentuximab for a year. As far as using maintenance brentuximab after transplant, certainly we have the data in Hodgkin lymphoma. We don't have randomized data in T-cell lymphoma. So I have not been using it routinely. Alex Herrera's study that I mentioned with the BV-CHAP, they did include it in their phase 2 study. So patients did get brentuximab in that setting. So, we have some data there. There actually is also a study that it's not quite opened. It's called the Brenticon study that is actually evaluating brentuximab maintenance after auto transplant, trying to answer that particular question. Although it's a phase 2 study, it's not a randomized study. So I'm not sure it will quite answer the question, but at least it will provide some safety data. And I think that, certainly there's a desire to use it, to do a little bit more. So I certainly would never fault anyone for considering it, because I think it seems reasonable.
Thank you.
Thank you. Dr. Arihant. Unmute yourself, Arihant.
Thank you, Dr. Allison and sir, for the lecture and the opportunity. So my first question is regarding the T-cell lymphomas who present with hepatic involvement or deep jaundice and bad liver enzymes at presentation, which is often due to either due to HLH or due to the infiltration. In those cases, and most of the, if we actually go by the recommendations, a lot of chemotherapeutic drugs tend not to be recommended and just steroids and cyclophosphamide often doesn't help. So how do you manage those?
So for patients who are presenting with HLH, I don't actually dose reduce etoposide in that setting, even if they have abnormal LFT abnormalities, because they're, the idea is that, we have to control the underlying HLH. And so I I actually would go ahead and, try to get that under control with etoposide and steroids, and then maybe lead into their standard treatment to try to, the standard treatment for their disease. So I think it's the tough thing is that, we know that these abnormalities are due to their disease. So I am hesitant to dose reduce so much, and so I will, what I would consider doing, even, if it's, I would consider just doing a lead in, potentially with cyclophosphamide to try to get it under control, and then quickly add in the standard approach. We're hoping that, the LFTs improve. It's always quite challenging. But another thing that, could be considered is using infusional chemotherapy. So EPOC, it certainly has all the drugs that, it certainly has activity in T-cell lymphoma, and, some people actually prefer that regimen for T-cell lymphoma. And I like that regimen for patients who are presenting with LFT abnormalities, because you're giving it, slowly over the 4 days or the 5 days. And so you can always stop if, the patient's getting worse. But the hope is that as you're slowly giving the treatment over the 5 days, you're actually seeing improvement in their LFTs by the time you get to the, their 5th day of treatment. And so that sometimes makes it a little bit more feasible.
Thank you.
Thank you, Arihant. Dr. Abhishek.
Thank you, ma'am. It was an excellent talk. You basically covered everything. 3 queries which I had last week also myself. So AITL especially, what about BV-Nivo, madam? Because AITLs tend to express a lot of PDL1. Like Hodgkin's, aren't you tempted to give them a combination like Hodgkin's of brentuximab, nivolumab? Second question is, where did ALK go wrong, madam, in this? ALK inhibitors in ALK positive lymphoma, can't see anything going right with them. And lastly, I'll ask you later on.
Okay, yeah, I'm going to forget the questions. So starting with, so BV-Nivo for potential. So the checkpoint inhibitors are unpredictable, I would say, in T-cell lymphoma. And, there's certainly some activity that we've observed in, in single agent studies with nivolumab in the T-cell lymphomas, but there's some patients who have hyperprogression, and I've actually seen it happen with a patient with angioimmunoblastic T-cell lymphoma have hyperprogression of stimulation of their disease from the PD-1 inhibitor, and we certainly also there's you see that in HTLV1 associated lymphoma as well, and so I think that we really don't have enough data to use these routinely in T-cell lymphomas and safely. There are some in the single agent studies with anaplastic large cell lymphoma. That's where potentially maybe it looks a little bit more active. So maybe there's some maybe that's something that we might consider in the future. But right now it's just not. It looks. It's a little worrisome. There actually was an interesting study that was presented looking at pembrolizumab I may be forgetting which checkpoint inhibitor. It was pembrolizumab or nivolumab in combination with EPOC for T-cell lymphoma. So you're looking at that in the frontline setting. And one interesting observation that they saw was that when you just give the checkpoint inhibitor starting off with the chemotherapy, they did see a lot of immune-related side effects. But they allowed patients to go on the study after receiving a cycle of CHOP, if they had received it outside and before coming on the study. So some patients were pre-treated with a cycle of CHOP or a cycle of EPOC without the checkpoint inhibitor before going on the study. And those people did not have immune-related toxicity once they started the combination. And so maybe, I think there probably is a role for these drugs, but maybe these patients need to be pre-treated with chemotherapy before going on to the combination. And I think, but right now it's not something that we're using routinely outside of clinical trials. I already forgot your second question.
ALK inhibitors.
Oh, ALK inhibitors, yes. Yeah, I didn't touch upon that. And certainly for a patient with ALK positive anaplastic large cell lymphoma, it is a strong, that would be after, if they've gotten brentuximab already, that would certainly be the next treatment that they would receive. In my personal experience with ALK inhibitors, you tend to see responses and they tend to be short-lived. So I think that, it's certainly the next treatment you would do, and, with the goal to try to get them to a transplant. And there, but it's, and so, and given that the ALK positive anaplastic large cell lymphoma diseases are, fairly rare, it just, it didn't come up in my talk, but no, it's certainly the next treatment that you would consider.
And the reason I asked you was AITL is supposed to be very highly PD-L1 positive.
Yeah, for sure.
ALK inhibitors work wonders in solid tumors. So probably a failure of precision medicine here.
ALK inhibitors in AITL.
No. In both cases, we had targets which were supposed to work very well, but it did not work that way.
Right. Well, I think that I think with the case with all of these targets, it's probably a matter of combining, dual targeting or figuring out, there's resistant mechanisms that unfortunately develop quickly. And that's why, I guess we'll see when we're bringing some of these drugs into the frontline setting and combining them with a CHOP backbone, maybe that's a better approach rather than waiting till they relapse and trying to give these drugs as single agents. But, we'll see.
Thank you, Dr. Abhishek. One question from the audience is related to lenalidomide, either alone or with romidepsin in relapsed setting. Any role?
Yeah, actually, that's absolutely there was a study that was led by Steve Horwitz as well with romidepsin plus lenalidomide in T-cell lymphoma that included patients with both systemic T-cell lymphoma and cutaneous T-cell lymphoma. There's certainly activity with this combination, and it's a reasonable consideration. It tends to be something that we think about, I guess later on, along the after trying other regimens. With lenalidomide certainly has single agent activity in HTLV1 associated lymphoma as well. And, it does have some activity in disease, in CNS lymphoma. So it's something that we might consider, for someone who has CNS involvement as well. It's a good option to think about after allotransplant because it might enhance the anti-tumor, the graft versus lymphoma effect. And so it's certainly a good consideration.
Thank you. Dr. P.P. Abdul.
Good evening, ma'am. I'm sorry, I've switched off my video because I'm somewhere outside, so connectivity is not very good. Thank you so much for the wonderful talk, ma'am. I think you have covered most of the thing, and others have also asked the question that I wanted to. But there's one thing, like T-cell lymphoma is somewhere I think is associated with history of frequent infections and inflammations and all. So where do you see this role of antibiotics, as we used to talk before, like some role of antibiotics in the treatment of T-cell lymphoma?
Are you particularly? I think I missed some of it, but I guess at least in cutaneous T-cell lymphoma, certainly, many patients who are super infected with staph, tend to have worsening of their disease, and so, that certainly seems to be implicated in worse of patients with more, again, basically with worsening of disease, and we certainly see that they tend to get better with so we're not currently really treating chronically with antibiotics, mainly due to the worry about resistance. And so there are some patients that I feel like I've had to, if they just, are recurrently seem to be getting infected, I am using sequential antibiotics, but I don't, it's more of an individualized thing and not something I'm doing routinely. I'm not sure if I quite answered your question though, if that was what you were targeting.
Okay, ma'am. Thank you. Yeah. And one more thing, ma'am. We have done a lot of things. I think in last few years there's been a lot of research, but still the backbone has remained CHOP only. So we have not whatever said and done. It is CHOP has been the backbone of the treatment of T-cell lymphoma. So do you really see a chemotherapy-free era in future for T-cell lymphoma?
I don't. I mean, one thing that was really interesting from Echelon 2 is that the patients who got CHOP did fairly well. So, with even the angioimmunoblastic T-cell lymphoma patients, their progression-free survival was about 50%, which is better than expected. And so I think one thing we learned from that study is that CHOP probably still should be the backbone that we build upon, rather than try to completely change to something completely new, because and I think we are starting. Well, hopefully we'll start to see some incremental improvements upon CHOP as we add the correct agents to them for the correct patient population.
Thank you. One more question from the audience is there a place of CNS prophylaxis in T-cell lymphomas?
So that's a difficult question. I don't know if we necessarily know the answer to that. Certainly in patients who have HTLV1 associated lymphoma, they're extremely high risk for CNS involvement. Often they have it at diagnosis to begin with, and so those patients are always going to get CNS prophylaxis. For all the other entities, I would say I don't routinely use it, and basically because it is rare with the T-cell lymphomas. We certainly do see it, but it's rare, and the role for CNS prophylaxis is not really clear. Now the role for CNS prophylaxis in B-cell lymphomas is not even clear. There were a lot of several presentations at ASH in the diffuse large B-cell lymphoma showing that it's unclear if high-dose methotrexate makes any impact, and so. So I think, given we already were unclear, now I think it's even less clear if we should be using it. So we're not using it routinely outside of HTLV1 associated lymphoma.
Right. Dr. Narendra Thota.
Thank you, sir, for giving this opportunity. And Dr. Allison, it was an excellent lecture. If there is any signal disturbance, please pardon me. I'm traveling actually. So this is about a case which I've seen and treated 2 years back. A 50-year-old gentleman, lymphoma, and he had initial CHOP, who had a response, then he had a relapse, then he was treated with a transplant, but he had a relapse again. So I evaluated him with the PET scan and other biopsy IHC. PET scan was showing an extensive disease, and there was a proliferative growth which is fungating and infected in the spinal area. And we did an IHC. IHC was showing CD30 positive, and PDL1 was more than 50% positive. So initially, I was in dilemma to give the GDP or other salvage protocol or single agent brentuximab, or combining brentuximab with a immunotherapy. So what would be your approach? Actually, I treated with the brentuximab, who had an excellent response. And unfortunately, he didn't have a transplant subsequently, but he had a relapse. That was a different condition. But what would be your approach for this patient? Would you like to use non-chemotherapy brentuximab with immunotherapy, or a single agent immunotherapy, or a brentuximab?
So a little bit of that got cut off, but what was it angioimmunoblastic T-cell lymphoma?
It's a peripheral T-cell lymphoma NOS.
PTCL NOS. So PTCL NOS got CHOP and transplant, relapsed, and biopsy showing CD30 positive T-cell lymphoma at relapse. Is that right?
Yes. It's
okay.
a CD30 positive and PDL1 more than 50% positive.
Okay. So I think what you did was very reasonable. I think it would be very reasonable to use the brentuximab alone. I wouldn't have used a checkpoint inhibitor or immunotherapy in combination with that. I'm a little less enthusiastic about brentuximab in PTCL, even when there's CD30 positivity. based upon that small series, in the relapse and refractory setting that only showed about a 33% response rate. So it doesn't look like brentuximab is necessarily any better than the other drugs that we have, such as HDAC inhibitors or pralatrexate, even when they're CD30 positive, at least in PTCL NOS. But it's, it's one of the options, and I think it's very reasonable. If this is just one of those scenarios where if there's a clinical trial, such as with a drug like duvelisib, which is showing a 50% response rate, that's going to be my first option before going to brentuximab, because, I think it's more active than brentuximab. But outside of a clinical trial, brentuximab certainly would have been my choice, and, and then with the hope to try to get them to an allo transplant.
And as PDL1 was more than 50% positivity, would you consider to add an immunotherapy?
I wouldn't, because it's because of the concern about. Well, I just don't think we have enough data in T-cell lymphoma. We have, examples of worsening of disease with PD-1 inhibitors, and so I wouldn't do that.
Thank you. Thank you, sir.
Thank you. Another question from audience is about hepatosplenic T-cell lymphoma. Any specific protocol?
Yeah, so this is completely different in how we approach this, and and there's not, because hepatosplenic T-cell lymphoma is so rare, there's potentially not one approach, but generally what we've seen is that these patients tend to respond better to platinum-based regimens as opposed to a CHOP backbone. So I don't typically start with CHOP. We typically use ICE or ESHAP for these patients. We tend to use ICE, and then we tend to try to consolidate them in first remission with an allo transplant from the start. Unfortunately, these patients can be really challenging to treat, and we have seen that. In our study with ruxolitinib, we saw some patients have responses to JAK inhibition. They do tend to have mutations in STAT5B or other mutations amongst the JAK-STAT pathway. And so, in the relapse and refractory setting, they may be eligible for some of these targeted approaches, but yeah, the hope is to try to get them to allo transplant in first remission.
Thank you. Another question is regarding aggressive NK cell leukemia.
Leukemia.
Yeah. Any?
Yeah. These patients are just extremely challenging. I just, we tend to treat them, using the same regimens that we use for extranodal NK cell lymphoma, such as SMILE. But I think that we don't have a great approach for these patients. I'd certainly try to get them to an allo transplant as soon as possible. I think that the most important thing for those patients is to make sure we have the right diagnosis, because there can be mimics. I've seen patients coming to us with a potential diagnosis of NK T-cell leukemia, and it ended up being something different, such as actually hepatosplenic T-cell lymphoma. Sometimes these patients can have NK LGL. It certainly would be associated with a more indolent course, and we certainly would not use such an aggressive approach. And so I think certainly one of the most important things is just making sure we have the right diagnosis, because with the aggressive NK leukemia is just such a poor prognosis and so difficult and so difficult to treat, and certainly would want to make sure that we're not over treating them if they're presenting in a more indolent way.
One of the audience wants to know, you handle pediatric T-cell lymphomas?
I don't.
We will skip that. Dr. Arihant?
So again, going back to HLH. So HLH cytopenias, chemotherapy already given in the background of a T-cell lymphoma. How safe do you consider using GCSF, or do you think it should not be used at all? Like the primary HLH has been targeted with the chemotherapy and etoposide and steroids, but can they help, or are they detrimental?
I don't think we have any evidence that they're detrimental, I do tend to use growth factor, on the days that I'm not giving the chemotherapy. So I'll give GCSF alternating. It seems like when the HLH is really active, I'm not so sure the growth factor doesn't seem to work very well, but I'll give it anyway. And then and it seems like you start to see it working once the HLH gets a little better under control. But I'm not aware of it being detrimental, and I do routinely use it on the days without chemotherapy.
Sir, with your permission, should I ask my question
Go ahead.
now?
Go ahead, Arya.
This is regarding, do you monitor EBV DNA quantitative PCRs while treating the NK T-cell lymphomas, and do you take any action on the results?
That's a great question. I do monitor it. I actually also monitor it for patients with angioimmunoblastic T-cell lymphoma. They also tend to be positive and it tends to track with their disease. So I do check it at, I certainly check it at baseline for the NKT cell patients, and we monitor it throughout the course. It's more, if the level goes up, it will make me worried. I still have to, if we still base upon their clinical response to treatment and, imaging. I certainly wouldn't act upon a new rise in EBV PCR without having any other evidence of disease progression. But it would certainly alert me that I should be looking deeper and, and looking for relapse if I'm seeing that come up.
Thank you. And one more question. So in a lot of T-cell lymphoma patients who do go into remission, but otherwise they should be consolidated with an auto transplant in CR1, but then they are not because of various reasons, and they relapse with a chemosensitive disease. Sometimes it's a very early relapse, and then they do go into remission with the salvage regimen. So at that time point, would you offer them an auto transplant or an allo transplant?
So for anaplastic large cell lymphomas patients, I would consider an auto transplant. For angioimmunoblastic T-cell lymphoma and PTCL, I really, even though those patients relapsed and even though they never got an auto transplant, they certainly seem to have chemosensitive disease. I just don't think that the auto transplant is that effective, even in that setting. Particularly, those, they're chemosensitive, but they relapse fairly quickly afterwards. And that was the patient population that we looked at Memorial, many years ago, because that used to be our routine, just to give them ice and auto transplant, and it just didn't work. It just came right back. So I feel like then we're exposing them to more chemotherapy before, and probably making it more difficult for them to get to an allo transplant down the road. So for the majority of those patients, I would still be aiming for an allo transplant.
And if we can just extend, so if it has to be an allo transplant, what dictates the intensity? To what I mean is whether you would use a RIC backbone or a myeloablative backbone. Is it the disease or the tumor which is deciding that, or it's based on the PS only, patient's performance state?
That's a good question. I think that I'm not often making that decision. It's our transplant group making that decision. In some degree, though, they are bringing into the factors of the type of lymphoma and the and really like the nature of their remission, and whether they're in complete remission or whether they still have some evidence of disease going into transplant. But I think most patients do end up getting a reduced intensity transplant, but I can't give you more details about that, though, because it's more that the transplant doctors are kind of making those decisions.
And two more questions. So T prolymphocytic lymphoma or leukemia, TPLL. So is there anything beyond alemtuzumab, or it's all about that?
Well, as outside of clinical trials, that's all we got, it seems. with that, and of course trying to get them to an allo transplant as well if we can. These are the we're enrolling those patients. We treated some patients with TPLL on our ruxolitinib study, and it actually about half of the patients had had benefit from treatment with some. They didn't last that long, but certainly had some responses because it's another entity associated with upregulation of JAK-STAT. And so now now that we have the combination study with ruxolitinib and duvelisib, we are enrolling patients with TPLL on that study, and we're allowing. Well, we're considering allowing them to go on even before trying alemtuzumab, given that would prefer not to have to give alemtuzumab, and worried about the toxicities with that, and particularly for someone who's older, where an allo transplant may not be an option for them. It's nice to have some other option besides doing alemtuzumab, because we're worried about the response not being very long lasting. So we're really aiming to, that's where we're really aiming to try to get them on a clinical trial.
Thank you.
Thank you, Arihant. Dr. Dipankar.
Ma'am, in a transplant ineligible elderly ALK negative ALCL with a partial response like a Duval's 4 on PET CT after 3 or 4 cycles of CHOP or CHOEP or a BVCHP, is there a role of radiation, or we can proceed to salvage with brentuximab and chemotherapy? So what should be preferred, and what is the role of radiation in a T-cell lymphoma?
I'm sorry, did the patient have localized disease to begin with, or it's a
systemic ALCL ALK negative with a partial response after 3 to 4 cycles of CHOEP or a BVCHP, any chemotherapy? There's a partial response. There's a Duval's 4 on PET CT.
Mm-hmm.
So what should be done after this? Is there a role of radiation? He is transplant ineligible. And is there a role of radiation or a salvage chemo with brentuximab? So what should be done in such a case?
Well, if the patient's transplant ineligible, I'm assuming that they have comorbidities and maybe difficult, once they're in the relapse and refractory setting. And so, I think this is probably an individual where, if they're resistant in just one area, I would say, why not try to, with the radiation, and see if you can get benefit out of that, and maybe continue on with the brentuximab maintenance. Unfortunately, I think the patient has a very high risk of fully relapsing and needing additional therapy. But I would say that that's certainly reasonable, since your hands are a little tied if they're not eligible for more aggressive therapy.
So, ma'am, we can do a salvage also with brentuximab. Like, we have given four cycles of brentuximab, BVCHP, and then there's a partial response, or Duval's 4 on PET. So, can we do a BV salvage with brentuximab, GDP, or brentuximab, and put on maintenance brentuximab?
If they have a very good response to BVCHP, the one thing is that it sounds like they are actually fairly a little resistant to treatment if they still have active disease. So, it's not, I wouldn't necessarily be excited about that approach, but if they really, are not in, if it's someone where you don't have great options, I don't think it would be wrong to try that, first before declaring, and seeing if you can control the disease. But I think most likely you're going to end up needing to do other treatment.
Thank you. Dr. Abhishek?
This relates to Hodgkin's. You have a lot of work in Hodgkin's as well. So 60-year-old gentleman, stage 3 Hodgkin's with a chronic liver disease, is having some trouble, had an episode of hematemesis as well, ascites as well, but he's good. Would you give a conventional would you give a conventional chemotherapy, or you would be tempted to use something new? resources are no bar to him.
No problem with resources, you said?
No, no problem.
So it's severe liver disease.
It's not severe, ma'am. It's child pug B.
Okay.
The bilirubin is 1.2. The PT is manageable. Difference is not more than 5. Albumin is, he needs albumin transfusions, but he is no longer has ascites. He had one episode of hematemesis, which was long back. He is okay right now.
Okay.
But he has cirrhosis of liver on imaging.
Okay. So I'd have to look back at the guidelines for brentuximab. I think that it's contraindicated in class C, but I'm not sure about class B. Or I'd have to look back. But I think that you probably can use brentuximab, but with a dose reduction. And so for patients in this age group or who with comorbidities, assuming he can tolerate combination chemotherapy, I typically will use sequential therapy. So starting off with single agent brentuximab, and for him, certainly a dose reduction due to his liver disease. And then that's kind of a trial to see how, hopefully he does okay with that and, seeing how he tolerates it. But, and then transitioning to AVD chemotherapy for 6 cycles. And, he also may need a dose reduction in that, due to his comorbidities. And then it's after the 6 cycles of that, and then it's going back to the single agent brentuximab. I think that would be reasonable to try, all with a lot of dose reductions. It's something, and then if it's really contraindicated for him to get brentuximab, then it's then going back to some of the older regimens could be considered, such as like chlorambucil based therapy, or even like CMOP based therapy could be considered. I think I would try to do the sequential BV and AVD regimen, because the results have looked so good with that regimen.
We were pondering on the regimes which could be used. Somehow we landed up on a consensus. What I don't know. What do you think about it? How about using a GDP in this case? That would be looks least toxic to the patient, to the liver.
So with cisplatin also,
we have no choice. Oxaliplatin would kill the liver.
No, I mean I think that my worry. I mean, I think that's fine. I think that the thing is, we just don't have data saying that that's a frontline treatment that, can be curative, and maybe maybe it will work, and maybe, but we typically use that as, for a salvage, with a plan for consolidation. So I just don't know how that, will be as a standalone regimen. But, I think, you got to do, it's just really tough with these patients. I think that probably if I really couldn't, I guess I think I would have considered CMOP, which, so cyclophosphamide, procarbazine. I think that's something what I was, but you just kind of have to make it up, unfortunately, when you're tied, due to these toxic, these comorbidities.
Can I ask one?
Yeah.
Ma'am, in most other lymphomas, which are the bad ones, we have landed up on CAR T. Where do you see that in T cell? It's a bad enough lymphoma.
So it's under development. There were 2 different CAR T studies presented in T cell lymphoma with very few patients, but some anecdotal responses. One of them was targeting CD37, and one of them was targeting CD5. The CD37 one, there was some prolonged cytopenias where the patients needed to be salvaged with allotransplant. So there's some concern there. There's, I think there's a lot of work in trying to develop these, and I think we'll see them in the future. We have a study with allo CAR T cells that are targeting CD70, and there's been some anecdotal activity with that in T-cell lymphoma. So that's something that maybe maybe seeing in the future, and then using different different cells, such as NK cells, or there's a lot of different concepts that are under development. So I think we'll see it in the future. It's just not something that has been very successful so far.
Okay, thank you, Abhish. Arihant, you have one more question?
Yes. So again, these are the rarer subgroups I'm sorry. So your take, and how do you manage the sicker enteropathy associated T-cell lymphomas diagnosed late in the course, hypoalbuminemic, landed up to the gastroenterologist multiple times, diagnosed late. That's the usual story. And then so you do the routine chop or mini chop, or there is anything new to offer to them? That's my
are you specifically talking about the enteropathy associated T-cell lymphoma associated with celiac disease, or
yeah, failing GFD, refractory celiac and EATLs?
Okay. So for EATL, or for enteropathy associated T-cell lymphoma, yeah, I mean, traditionally we have been using the standard, CHOP plus etoposide followed by transplant. These diseases do tend to express CD30. And actually there was a nice presentation at ASH of a study with 14 patients, which, because it's super rare. So that's a study. And it was with BV chip. So, the BV chip based regimen for 4 cycles, followed by high dose methotrexate and etoposide, and then followed by auto transplant. And, they showed nice activity. It was, I think, about 2/3 of the patients remained in remission in a prolonged way. So that's, that is an approach, I guess, we would nowadays use brentuximab as part of the frontline treatment, given that they're CD30 positive. But that's, it's really tough right after they've gone through surgery. Sometimes they have open abdominal wounds that are not healing, they're, and they're, you have to be really careful. And what I tend to do is, if I was using standard CHOP, I tend to hold off on the vincristine with their first cycle, because I'm worried about causing constipation and, putting pressure on their bowel and anastomosis. And certainly starting, I never think it's wrong to start off with a dose reduced treatment, while to see how they tolerate the first cycle, given that, they may be quite deconditioned from everything they went through. But in general, it's the standard treatments that we're using.
Thank you. So one more kind of a real life question in our scenario. So a patient of CD30 positive lymphoma relapsing with the frontline chemotherapeutic regime, say CHOIP or CHOP, and then he has a fixed finance, say, and he has an option either to go to a second line pure chemotherapeutic salvage, say ICE, 2 or 4 ICE followed by an autologous transplant, or a targeted, say, BV ICE combination for 2 to 4 cycles. So if you have to choose between the two, what would you offer them in the current day and age?
So the choices are ICE and transplant, or BV ICE with no transplant.
Yeah.
Well, that I think that's tough. I guess I would not be. I'd be worried about offering transplant at all. I don't think that either one of these would really be my choice. My worry is that no matter what, either way, I think the patient has a very high chance of relapsing shortly afterwards. And so really my choice would be something that can be sustained if we can't go to transplant. We can't go to allo transplant. And so, it would be romidepsin, belinostat, pralatrexate, one of these agents would be more of what I would opt for. Gemcitabine, I mean, I always love gemcitabine. I mean, if you don't have those other agents available, then gemcitabine-based therapy is reasonable. The thing about giving, possibly Gemox, or sometimes, I mean, we've kind of made up a regimen where we give gemcitabine plus etoposide and prednisone just because they're all good drugs for T-cell lymphoma. So that's something where you can maintain things in a more palliative way if that's all you have, if that's all you can do. But like whether you do ice and transplant or BV ice and then nothing, I think that you're going to get a quick response, but I think it's going to come right back.
And your take on bendamustine in T-cell lymphoma?
It has activity, but it tends to be, I think the activity with bendamustine tends to be short-lived, but certainly could be considered as well as a down the road option. It's better as a bridge to something because I don't think it tends to have much durability.
Thank you.
Thank you. There was a similar question about purine analogs in general. Are they effective in these T-cell lymphomas? Purine analogs.
We don't tend to use them. We tend to use them in. I mean, it's just not really. Doesn't tend to come up.
Right, Dr. Abhishek.
I'm just taking Aryan's question. Hodgkin's relapse. Brett, this is my personal opinion. You might differ. Using BV Nivo or a brentuximab or a bendamustine Nivo rather than giving the traditional chemos, I found out that using a couple of cycles of these newer agents far better than using the traditional chemotherapies in a relapse setting. Would you say that's right? Should we be doing that now more often if kinases is not a concern?
Yeah, absolutely. I am very rarely giving ICE as a second-line treatment for Hodgkin lymphoma now. I think that until recently, my treatment of choice, my second-line treatment of choice was brentuximab plus nivolumab. The activity is really good, and I do think that there's a sense that patients have more durable remissions. Who are going into transplant, who have gotten a checkpoint inhibitor before transplant. And there was a retrospective study that was presented at ASH that kind of suggested that, although there's so many, it's biased to kind of look at that, but it does appear that they improve the outcomes. We're now very excited about a regimen that we were looking at with pembrolizumab plus GVD, so gemcitabine, vinorelbine, and Doxil. The complete response rate that we saw with this regimen was 95%, which was, kind of blew our minds. We didn't expect such a high response rate. So, and it actually just recently got added to the NCCN guidelines. So now we're able to give this regimen off study, although we still have a study where we're looking at this regimen. And, right now I'd say the standard, would still, of course, be to try to consolidate with an auto transplant in the relapse and refractory setting. But given that the regimen has looked so promising, we're actually studying a non-transplant approach using this regimen where we just proceed right to pembrolizumab maintenance rather than transplant. But I absolutely agree with you. These novel agents are very, very active in this setting. And if you can get them, I would certainly try to do some kind of PD-1 based regimen as the bridge to transplant.
Ma'am, this basically asked you because I learned it the hard way. In few of my patients where chemo did not work, actually it just melted away with a brentuximab with nivolumab or a bendamustine nivolumab. After ICE, DAP, means they had partial responses. Finally, last ditch, I switched over to them, and 2 cycles it just disappeared.
It's amazing.
So basically they are there and they are amazing, but that is why I'm asking you, should we offer every patient day one? It is their choice. They won't take it because of the finances, but they should be the number one choice in a relapse setting in Hodgkin's, right?
That's what I would do. I would do it from the start. I mean, we thankfully have it available. It's a lot easier for us, but I would definitely, if you can get it, I would say that that's a good way to go from the start. And actually, another question I thought you were going to ask if you should still take the patient to auto transplant after failing all of these cytotoxic regimens, and I actually would, because I mean, otherwise you have, you're potentially giving them a PD-1 based therapy forever. You never know when to really stop it, and there actually are some now retrospective series showing that even after failing all these treatments, patients, some patients have been taken to auto transplant after getting PD-1 therapy and have had, nice, sustained remissions. I think, it's the idea that maybe the PD-1 is sensitizing the patients to chemotherapy. So maybe it's making the auto transplant work better at that point.
Ma'am, in all of these cases, by default, we had to take them because we do not have so much resources to keep patients on PD-1 inhibitors. So after a couple of cycles, most of these patients went into CR and we took them into an auto.
Amazing.
Because we did not have the luxury of a PD-1 forever.
Right. So we have that luxury, but I still don't think it's a good idea.
Thank you, ma'am. Thank you, ma'am.
Ma'am, just last two questions. One is about Sézary syndrome. What is your protocol?
So it depends upon how sick they are and, how symptomatic they are when they present. Even though it's an advanced stage CTCL, even though it's in the blood and, they'll have widespread erythroderma. Some of these patients, when they present, they've been having this for months to years, and until the diagnosis is finally made, they may not be absolutely miserable. And so, often my frontline treatment would be to start with a retinoid, such as bexarotene, and that sometimes we can use that to control the disease for a prolonged period of time. And we might use that in combination with photopheresis or interferon. For patients who are much more symptomatic, who are just, much sicker, then I think then we need to do something that's going to work faster. Of course, bexarotene is great because you can use it for a long time, but it takes sometimes months before it's really starting to work. And so in the past, it used to be that my frontline, kind of more aggressive approach or after bexarotene would be romidepsin. But now I'm going to mogamulizumab first, because that is, the CCR4 monoclonal antibody. It's very active for patients who have blood involvement with CTCL. It's very effective in clearing the blood, and we tend to see a pretty brisk response with this. And it's just better tolerated than romidepsin. You don't have all the bad side effects of an HDAC inhibitor with fatigue and GI upset. And so that's my go-to. And romidepsin has kind of moved to more third line or beyond for these patients.
Right. And just last question before we close. How excited are you about this oral azacitidine in treatment of T-cell lymphomas? What is your?
I'm excited.
You're excited about it.
It's not. It is something that I've only really used it as a single agent for patients who are so sick, and I've run out of all the options. So I guess I haven't personally had as much success with it than we've seen. It was the series where it showed activity was about 12 patients. And so it was really, really small, but the response rate in the T follicular helper diseases was like 75%. So it certainly looks very, potentially promising. And so, and I have to say, I did participate in the study where we were giving oral azacitidine with CHOP in a phase 1 setting before, that was the lead-in into this randomized study that's just opened. And the patients tolerated it great. It didn't really affect the toxicity of the regimen. The patients that I treated on the study are doing very, very well. And so I think it may improve the activity. And, of course, we'll learn that from this clinical trial.
Thank you. So this was wonderful lecture and then wonderful question answer session.
Thank you.
Answered everything. Some of the tricky patients as well with limitations that we face here in this part of the world. Thank you so much. And for the official vote of thanks, we have Mr. Ashutosh.
Thank you, sir. Many thanks to Dr. Allison for a wonderful talk on T-cell lymphoma. Thanks to all the discussions for making today's webinar a very insightful and interesting one. I'm sure all the participants must have felt the same. I'm thankful to all the participants for sparing their valuable time this Saturday evening. I'm also thankful to our event partner, Mice Ideas. Last but not the least, I am thankful to Team Adley for their follow-ups with all India doctors in making the event a success. Thank you so very much. Good night.
Thank you, Dr. Allison, once again on behalf.
Thanks again for the invitation.
Thank you, madam.
Have a wonderful day.
Take care.